Okay, so hello everyone, welcome back to SME Symposiums. Good evening. My name is Ehsan Salim. I'm going to be your host this evening, and we're discussing fundamentals of end-of-life care. I know we're waiting for some more people, but just for the sake of punctuality, we'll get started. Okay, so I've added a new segment in today, and it's just really for people who are joining us for the first time, because every month we have new people. So it's a little about what we do over here at SME Symposiums. Essentially, we're a department of Study Medicine Europe. And what we do is we've decided about a year ago now to make monthly webinars. And they're really just a passion project that's dedicated to keeping you up to date on relevant and important medical topics. So we get interesting speakers from pretty much everywhere and discuss important topics that are relevant to students, especially IMGs and international medical students planning on coming back to the UK. So that's really the target over here. The other thing is everyone is welcome if you're an SME student or non-SME student. And the other thing is, though these webinars do cost us to make, we've made sure that they are free for everyone. Okie dokes. So a bit about our speaker today. Our speaker is going to be Dr. Ehsan Salim, who's going to be discussing the fundamentals of end-of-life care. So Dr. Ehsan Salim is a graduate and honorary fellow of Glasgow Medical University, and that's where he graduated from. He also has an intercal degree in public health, I believe, and is currently a FY2 in the Academic Foundation Program at the Queen Elizabeth University Hospital in Glasgow. And surprisingly, he's also the founder of the Glasgow University Medical Education Society. I think we've had him on a couple of times before, and he's quite passionate about this topic specifically. So I'm really excited to have him on for it. So the program for today is, I'm just doing my little welcome introduction right now, and then I'm going to hand it over to Dr. Salim. And at the end, we will have a Q&A. So basically, we don't have a chat box function for this webinar. But for those of you who do have questions, I'd love for you to just put them in the Q&A as the webinar goes along. At the end of Dr. Salim's presentation, I will go through the questions and direct them to him one by one. And of course, a big thank you to our sponsor, Lectorio, an all-in-one study resource for medical students that combines learning, science, and medical education into one easy-to-use platform. Now, they've been kind enough to also give a 50% discount code to us for a yearly subscription, which you will get at the end once you fill in the feedback form for today's webinar. And they've given us a few free passes as well, 6-month passes, which I'll be handing out. We just pick people at random just to keep it fair. Okay, I think that's pretty much it from me. Without further ado, I'm going to hand it over to Dr. Salim.
Okay. Right. Okay. So thanks very much for the introduction, Mohsen. My name is Ehsan. Like Mohsen said, I'm an FY2 at the moment at the Queen Elizabeth University Hospital. Currently working in histopathology, and my next placement is in Beatson, so that's oncology in Beatson. And today I'll just be talking to you a little bit about the fundamentals of end-of-life care. I'm going to go through the most important aspects first. So things like why palliative or end-of-life care is important, who are the teams that are involved, what kind of aspects involved, and then towards the end we'll get more to things like what it is important for you to understand specifically as an FY1 or FY2. What is it that you really need to know when you're on the wards? So that will be kind of the structure of the talk today. And then right at the end, I'll just tell you a little bit about my experiences in the hospital, especially on night shifts, and what I've seen and what I've found very useful as well. So without further ado, we'll get straight into it. I'm aware that I have 40 to 50 minutes, so I'll let Mohsen keep me right as far as that is concerned. But we'll just go with the flow as we go along. Okay, so let me just get this going. Yes, fantastic. So I guess the best place to start is just to understand what the definition of palliative care is. And this is the definition from the World Health Organization. And basically it says an approach that improves the quality of life of a patient and their families facing problems associated with life-threatening illnesses through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, or spiritual. Now, in this definition, I've highlighted or underlined a few keywords, and I just want you to take a second to just look at those keywords, and we'll come back to this at the end. And I hope that by the end of this, you'll understand why those keywords are so important within this definition, and why they're very, very relevant to palliative care and end-of-life care. So just have a look at those keywords, and we'll be coming back to this slide at the end, and I'll be asking generally all of you some questions about it. So palliative care. We need palliative care because cancer is one of the biggest killers in the world. It is so widespread. You can see this is just a statistic from 2017. There are millions and millions of people affected by cancer. And when it comes to terminal illnesses, cancer is one of the biggest causes of this. And so a lot of diseases become terminal in the sense that there is no further treatment, or there is no more medical treatment that we can offer the patient to either slow down the progression of the disease or to actually cure them. And so when a patient gets to that stage of their disease progression, the focus really shifts from how do we fix this to how do we manage this? And that's an important distinction to make. And another thing, just on this note, that I want to highlight, that palliative care is not only for cancer. It could be any terminal. It could be motor neuron disease that is often terminal. We don't really have proper, sufficient treatments for that, and we can't really cure it as such. So there comes a point where the active treatment of the patient is no longer having any effect, and therefore we have to just do symptomatic control and managing the symptoms as opposed to treating them. And so it's not just specific to cancer, but I mean, this graph is just to illustrate that there is a massive need for palliative care, especially in today's world where patients are living longer and longer and longer, they're surviving longer, and then they get to elderly age where surgery is no longer an option, often chemotherapy is no longer an option, and so they need palliative care to make their life comfortable and to improve their quality of life. So there's a very, very specific need for this. And what I want to talk about a little bit is who provides palliative care. And the easy answer is that everyone involved in the patient's care provides palliative care. So what I need you to understand is that there will never be a situation within the NHS anyway, where there is one person involved in the palliative care of the patient. And therefore, what you really need to understand is that you will always be coordinating with their GP, with their physiotherapy team, with the palliative care consultants, of course. You'll be coordinating with the pain management teams. You'll be coordinating with the pharmacy teams, because, and I will get more into the detail of this, of how this actually works and how we actually pursue palliative care. But it really is a holistic approach. And it becomes a lot less about the treating clinician, like the neurologist or the surgeon or whoever. And it becomes a lot more about the specialist nurse services and the pharmacy services and the GP services and the community care services. That's what it really, really becomes about. The focus totally shifts. As soon as someone becomes palliative and we're like, okay, we can no longer treat this condition to an effective level, it really just becomes about their comfort. And so the whole dynamic of who is the primary caregiver or who is the decision-making machine at that point changes completely. Okay, so it's a big, big team that's involved, and it often involves pretty much everyone that's involved in the care of the patient. And this will make more sense as we go along, right? So just on that topic, the key people are the palliative care specialists. So that includes consultants and nurses. They're both involved in palliative care. So palliative care specialist nurses, palliative care consultants, a combination of, like I said, specialist nurses and doctors. And what do they bring to the table? What do these palliative care teams bring to the table? They bring an in-depth knowledge of end-of-life care. These people have managed thousands of other patients who have end-of-life diseases and end-of-life conditions, things like, terminal lung cancers, terminal pancreatic cancers, metastatic esophageal cancers. These people have managed so many of these patients. And so they know really, really well how to manage pain symptoms. Okay, they know how to manage mental health issues, things along the lines of anxiety, depression, withdrawal, and they also know how to manage, disease-related symptoms. So, for example, people who have, a terminal cancer of the GI system, or gastrointestinal cancer, can often present with obstruction. So they can no longer, pass bowels and pass, flatus and food through. And so they have very excessive secretion. So they know medications and drugs that can also be used to manage those conditions as well, beyond just pain management and mental health management. They can really, really effectively treat disease specific conditions. Okay, and beyond the medication and the medical point of view, they actually are very, very efficient at figuring out what the best location for the patient is. So often the hospital is not the place patients want to be in their last days. And to be honest, hospital is not the place anybody wants to be, but often hospital is not the place that patients want to be even for any length of time. Okay, they're just there because they have to be. So it comes with no surprise that it's not the place they want to be when they get to the end of their life. And so what you really need to grasp here is that a lot of the palliative care services that are delivered within the NHS in the UK are done in the community. If the patient desires and it is feasible for us to make it practicable, people will go and the service will go an extra mile to make sure that that person can go home and receive the care that they need, the end of life care that they need at home, so that they don't have to be in a hospital where it's often, like a multi-bedded ward. They have very little privacy, their family come in and have very little privacy. So we do our best to try and make sure that the patient can, or it can be facilitated, that the patient can either go home or to some sort of like care home or nursing home or something like that, where they can have a lot more privacy, they have more space, there's more staffing available for their needs. Sometimes that's not possible. Sometimes patients are quite complex. They might have an NG tube, they need constant monitoring of their urine output, we need to fluid balance them, and things along those lines. And so it becomes very difficult to facilitate something like that outside of a hospital environment. But a lot of the time when it comes to palliative care and we identify it early enough, then what that would mean is that we can facilitate or plan for them to be sent out into the community where they can receive the exact same quality of care and comfort without having to be, within a hospital where they're effectively, like, you could say, trapped really, and just not comfortable. So that's an important aspect. And finally, the palliative care teams have a great access to specialist services and facilities. So they're very, very much in touch with, pain management teams, physiotherapy teams, a variety of other, pharmacists and their special expertise. They're very much in touch with those people and can really figure out the services and the facilities available. They also have extensive access to funding of various sources, which can fund things like, places in specialist, care homes or for end-of-life care homes, and basically facilitating the family to come up and transport, and they have access to a variety of charities that will fund and help the patient with, their various needs. Okay, so those are the things that the palliative care team provide overall. I'm just going to take a quick second to look at the question to see if there is any questions so far, and I will take that as a no. But we'll continue. Just wanted to check if there was any specific questions. But I guess the point of that slide was to highlight to you the kind of variety or the breadth of the services, or the kind of services that the palliative care team provides. It's beyond just the symptomatic and medical management. It's also to do with location, family conversations, and facilitating end-of-life care in the community. The main purpose, you could say, of palliative care or end of life care is to remember that we want to maintain the dignity of the individual, and to treat someone with or to give someone, to treat someone with dignity is to treat them with respect, esteem, and regard. You have to remember that though these people might be at the end of their line and there's no further treatment available for them, and their prognosis might not be great, they might have a couple of months or a couple of weeks or a year to live, it still doesn't mean that this person that you have in front of you was once a CEO of a company, or once the head of the hospital management. He was once the kind of leading whoever. It doesn't matter. This person is a human being who's had a life, who has a family, who has achieved things. You have to treat them with the same respect you would treat another patient who may be expected to live another 10 years. And so it's even more important to make sure that they're treated with esteem, they're treated with respect, and their wishes are respected most and foremost. So what we try to explain to particularly medical students is that respect, is what is deemed important by the patient. Treating them with the same respect you would treat any other patient, regardless of their current state or predicted outcome, and having appreciation for their values and morals. And this last point is very crucial. We often forget, or we often become very, medically minded, and we think, okay, how do I treat this patient? How much medication do I need? How much painkillers do I need to give him? What do I give to stop the secretions, in his mouth? Or, when do I put in the NG, or do we commence NG? Those are all important, and they're important aspects of medical care, but also the things that we often don't ask ourselves or ask the patient sometimes is, does this patient need somewhere to pray? Is it important to him to have somewhere to pray? Do I need to call the hospital pastor or the hospital imam or whoever to come and speak to this patient because he has religious needs or he has spiritual needs? Does this patient want his family around him at the last? Does this patient not want his family around him because he doesn't want them to see him in that state? So those are all very important aspects. Those values and morals that are precious or valuable to the patient become very, very precious, particularly in their last days or the kind of their terminal times. And that's something that often as clinicians, we don't acknowledge or pay attention to because we're so focused on the kind of medical treatment. How do we medically treat this person? How do we get him better? And we kind of get lost in that kind of world of it. So having that kind of compass and understanding is crucial, right? This is the part I feel like is probably most practically important. This is the part where I feel like it's most practically important for junior doctors. So though that's FY1s, FY2s, and even IMT1s and onwards, I feel like this is something you need to know. And I've seen this in my OSCE stations as well when I was a medical student. And it comes up in OSCE. It's not surprising, this come up. And it's the aspect of important discussions. There are a couple of important discussions that need to be had with the patient and their family or their guardians near the end of life when you're planning for palliative care. And the first thing, before I even get into what these discussions are, I want to just focus a little bit on how we have these discussions. What is the kind of etiquette or the kind of appropriate manner in which we should have this discussion? And this is a very well-known kind of format, SPIKES. So setting, perceptions, invitation, knowledge, empathy, and summary. So this is it's a well-known kind of you can say algorithm or table that kind of sets out exactly how you should be having these serious conversations. This model can be used for breaking bad news, so telling someone that they may have a diagnosis of cancer or they may have terminal illnesses. It can be used for sensitive conversations, so like things like HIV diagnoses and other things. And also it's used for pertaining to this talk, for things like end-of-life care, palliative care, making a patient palliative, DNA CPR conversations and things like that. So I'll go through it very quickly, and obviously the slides are there for you. But setting, so ensuring that whenever you're about to have an important conversation or important discussion with either the family or the patient or both, that you have a nice, quiet, private room. And if you have a pager, you give the pager to one of your colleagues or you turn it off for the duration that you're there. Now, I appreciate that's not always practical. Sometimes you're on the crash call pager, but you need to make sure that someone has cover for that while you're having this discussion. I mean, the last thing, if you can imagine, the worst situation would be if you're breaking bad news to somebody like a patient, and then suddenly your crash call pager goes off and you have to rush out the room because you've not arranged someone to cover for you. So I think that's very, very important, to have the right setting, not having any distraction, having a quiet private room. Perceptions, I feel like the first line there, it kind of sums it up. You always ask the patient, tell me what you understand about your illness, or tell me what your understanding is. This is crucial before you start talking, because number one, you don't want to say things they already know, because that can be frustrating. Number two, you don't want to say too much that they don't know, because that can be shocking. So you want to gauge where the patient's understanding is of their illness or of their disease or whatever, of their situation. So that's their perceptions. Invitations, you ask them, if they would like a family member to come with them, before. So you pre-arrange it. You say, I'd like to have a chat with you tomorrow afternoon at 2 p.m. If you're available, would you mind, or would you like a family member to come with you? Now that has two purposes. Number one, it's really, really, a lot of patients want a family member there because number one, they feel like they can't handle whatever they're being told in the moment. Number two, they feel more comfortable with the patient, with the family member being there. So that's why patients want someone there. But also, as soon as you say, would you like someone to come with you, it kind of acts as a kind of a warning shot, like, whatever I'm about to discuss with you is important. Therefore, would you like to have someone there with you? And that warning shot is really, really helpful to kind of prepare them for whatever news is about to come, good or bad. Then knowledge. So you basically, you to give them a little bit of information, along the lines of, I have something serious that I want to talk to you about, or I want to discuss this with you, and you tell them what the actual situation or the point of the topic is at the time. You demonstrate empathy, so you give time, you allow them to absorb the information. You may have done this 110 times, but for that patient, it's their first time. So you have to give them space. You have to demonstrate empathy. You have to demonstrate that you understand what they're going through. And then finally, summary. Whenever you have such a conversations, the patients will miss the details. You might give someone a diagnosis of cancer. You might tell them that it's terminal. You might then give them a plan and some details and some information. And I promise you, they will have forgotten 80% of what you said before they leave the door. So it's important to have a brief summary of what you've talked about in that meeting. And at the same time, this is why it's very useful to have a family member there, or a guardian there, because that family member or guardian will probably remember or retain a lot more than the patient himself, simply because they're less emotional about the situation. So I think that's crucial to remember as the summary at the end. So now that I've told you a little bit about how to have an important discussion, I'm going to tell you about what the important discussions are that you may need to have. I say you may need to have, I think you may need to be, you will most likely be sitting in, with a consultant or a senior doctor when it's being had, especially as a junior doctor. But as you progress through the ranks, you will be the one having these conversations. So the first one that I want to talk about, a DNA CPR, right? A DNA CPR is basically a decision made by the patient or power of attorney of the patient and the doctor to determine that in the event of death or cardiac arrest, the patient will not be resuscitated. Okay, it's an active decision that is made by the clinician and the patient's family to determine that it's basically we're not going to resuscitate this patient if they were to their heart was to stop beating. And this is based on two main things. It's based on, number one, the patient's desires or wishes, and number two is based on the medical assessment or to determine the likelihood of success. Now let me explain this a little bit. There is no set percentage that we can say, oh, this person, if we resuscitate him, he has a 5% chance of. There is no official step. Obviously, every patient will be different. Every prognosis will be different. Every condition will be, the progression of every condition will be different. Every condition itself will be different. So you can't really put a number on it, but an experienced clinician like a consultant will be very quickly and very effectively able to tell that if this person's heart stops beating and if we attempt to resuscitate, the chances of success are immensely low, immensely low. And what you have to understand is that there are statistics out there, and I remember looking at them a long time ago, but the chances of someone being successfully resuscitated in hospital are lower than the chances of someone being successfully resuscitated out on the street. Okay, so if someone falls down out on the street and you start resuscitating them, their chances of success of recovery are higher than someone in hospital that crashes and is given resuscitation. And this is purely because, I believe so anyway, it's purely because the patient who's already in hospital is so sick, he's already sick on top of whatever illness he has, and then his heart stopped beating. Whereas the person outside was walking 2 minutes ago and was active 2 minutes ago, and his heart still stopped. So you have to understand that people who are in hospital are sick, and a consultant will be able to tell straight away, in their expert field of expertise, that this patient has reached the ceiling of their medical care, in terms of there is no further thing that I can provide for this patient that would improve his chances of survival. And therefore, if his heart or her heart stops beating, in the next 10 minutes, if I do resuscitation, the chances of survival are so low that it's not worth putting them through the trauma of resuscitation and the indignity of resuscitation to basically make it worthwhile doing. Remember, medicine is a balance of risks and benefits. And this is exactly one of those scenarios where we weigh the benefits of resuscitation against the risks of damage, harm. Even if you manage to bring them back, you'll have damaged them so much that their life, or whatever is left of it, will be incredibly painful and miserable. So we have to have this balance. And what I want you to understand is that as a junior doctor, this is crucial for you. This is absolutely, and I'll come again back to this again at the end, but this is so crucial for you, because imagine you're on 4 surgical wards, so that's 28 beds per ward, and you're looking after more than 100 patients by yourself at night. So you're the FY1 on those wards, and basically there's a sick patient on ward D, and ward D, room I don't know, room 72. Okay, he's a very, very sick patient. He's had surgery, he's got metastatic cancer. They perform some surgical procedure, they don't think that he's going to make it for long. And imagine you know that patient is on one of your wards. The last thing you want, the last thing you want, is to be running to a resuscitation call, knowing that the resuscitation is massively unlikely to be successful. Because once you start resuscitation, you do not stop until a senior consultant makes a decision, or a senior doctor decides, okay, we're going to stop now. And so if that person crashes, that incredibly sick person crashes, and you have to run to you're going to be doing resuscitation on this man who's effectively dead. You're going to be calling 2222. You're going to have the whole crash team coming for you, and they're going to attempt to resuscitate him, attempt to intubate him, cause immense trauma, fail, okay, before a consultant then says, or a senior doctor says, okay, we're going to stop now. Okay, so having a DNR in place, or a DNA CPR in place, is crucial, absolutely crucial, to ensuring that unnecessary intervention is avoided. Okay, and you preserve the dignity of the patient, even if you can't preserve their life. And that's important. So this is almost a crucial aspect. Whenever I go on a ward and I know there are sick patients, or someone tells me, I have a 78-year-old man who's incredibly sick, his news is 8 now, his pyrexia, he's on multiple antibiotics, and I would always ask, is he DNA CPR'd? Because that tells me how much I need to worry. Because if that man is not DNA CPR'd and his heart stops, I need to be running. Whereas if that man is DNA CPR'd and his heart stops, we accept that he's passed away and we provide no further treatment. So this is a very, very crucial differential for you guys as junior doctors and SHOs. And the other last thing I want to mention at this point, I'll obviously keep track of time here, is that advanced directives are basically almost like a patient's will, or a patient's wishes that he prepares in advance or before he becomes incapacitated, and it basically details what he would like done in the event of his heart stopping. So whether he would like certain treatments or not like certain treatments, whether he would like to be resuscitated or not like to be resuscitated, whether he would like his family to be contacted or not. It details what the patient's wishes are for their end of life care. That's an advanced directive. Okay. So often patients will have a DNA CPR in their advanced directive, right? This is the document that we fill out for our DNA CPR. I apologize, it is quite pixelated, but it was the one I could find. It's the one that we use in the NHS. It's quite detailed. It often has to be done by a senior clinician. You have the details of the patient up there. You go through various check boxes, and then you basically sign and date at the bottom. There's multiple pages to this. There's also a section for a discussion with the family, which is absolutely crucial. And basically, you have to detail which member of the family that you've had the discussion with. If there's a power of attorney, you need to make sure you've detailed, the conversation with the power of attorney as well. Okay. Right. The second important discussion I want to talk about is the initiation of palliative care end of life. This is an active decision, right? Now, I'll give you a scenario, and I want you to envisage this scenario. Imagine you have a patient who has pancreatic cancer, and pancreatic cancer is a dreadful cancer. And so he's had a Whipple's surgery to remove the head of the pancreas, along with extensive removal of the bowel and stomach. And he's had multiple bouts of chemotherapy, and he was then discharged home. He was well for a few months, and he suddenly come back in with acute hemoptysis. So he's coughing up blood, he's got chest pains, and he's struggling to breathe, he's short of breath. He comes in and you do a CT scanning, you find multiple metastases to his chest. So obviously you did your best to remove the primary cancer. You didn't successfully remove all of it. It's now metastasized to his lungs or his liver or wherever. And now he's having symptoms of that. At that point, often there is no further treatment. Okay. There is no further treatment to try and cure or prolong life at this stage, because you've given him the surgery, an extensively harmful and difficult surgery. You've given him, chemotherapy. You probably have given him adjuvant radiotherapy, and he was well for a few months, and now it's come back with a vengeance. It's metastasized to his lungs, and he's got extensive symptoms. There is nothing else you can do for him. No further chemotherapy protocol exists, nothing that shows or any evidence of benefit anyway. And so at that point, you make an active decision to palliate that patient. This is an active decision. It's not just, oh, we'll do what we can. No. It's an active decision. You've decided to palliate that patient. Therefore, no more chemotherapy, because you're not chemotherapy is going to make his symptoms worse, not better. There is no evidence that it will make his survival or prolong his life. So you're not going to give any more chemotherapy. Otherwise, you're just going to be causing him more pain. So you've decided we're going to palliate this patient. So you make an active decision. And this decision you must discuss with the patient and his family together. A lot of times, family members will think as soon as you palliate that patient, that you've kind of given up on them. Oh, doctor, we've given up on my dad or my mom. How can you say that you're not going to treat him anymore? It happens, and this is, some people feel very strongly about this, and they don't have the in-depth knowledge of the benefit of perception of that you have, in terms of there is no further treatment for this. So they will argue sometimes, and they will take this as a shock. So having an in-depth discussion through, using the spikes model or whatever model that you use with the family and the patient together or separately on 2 occasions or 3 occasions is crucial to having these discussions, because you need the family on board. Because believe me, they're relatives. We all have relatives, we all have family members, and we all feel very strongly about those things. If one of my family members was in the hospital, I would like the hospital to do everything they could to make sure they prolonged their life and make sure they got better. And it can be very difficult for anyone to accept that, okay, we're not going to treat this patient actively anymore. And so you must try and have this discussion with the family and get them on board. Otherwise, they can make your job incredibly difficult, and it's bad both ways. The last point there is the focus shifts from treatment to comfort. Okay, but what's highlighted or in bold down there is that this does not mean you cannot give therapy to treat illness. So, for example, this patient who's coming with metastatic lung cancer from the pancreas might also have a chest infection. Just because I'm palliating that patient doesn't mean I can't give him antibiotics, because not only will the antibiotics treat the chest infection, but it also help him feel better. It will improve his symptoms. It will make him feel better. If you have an infection in your chest and it's causing you to have pyrexia and fevers and temperatures and rigors, giving antibiotics is not just for treatment. Pardon me. It also acts to help alleviate their symptoms. So just because someone is palliative doesn't mean they cannot be actively treated. You're not actively treating their cancer, but you're treating the complications of their cancer. So if that cancer then spreads to the patient's heart or pericardium and he has heart failure, you can give him diuretics to pee out the excess fluid that he's going to have as a result of peripheral edema because of the heart failure. So just because it's not just pain medication or antiemetics or anticonvulsants. You can give active therapy to patients even if they're palliative, because you know that treating that infection or treating that complication will fix their symptoms or improve their symptoms. So just because they're a palliative doesn't mean they can't have active therapy. Okay. And this point needs to be highlighted to the family as well. You say to them, it doesn't mean we're not going to treat them. We're going to do everything we can, but we're just not going to put them through more pain or more unnecessary pain. So we're not going to give them any more chemo because it's going to do more harm than good. Okay. Right. Last thing I think there should be, this is more of a discussion, not with the family, but within your team, within your clinical care team, is something called ceiling of care. Okay. And there's quite a lot of detail of how you arrive to a ceiling of care, but really, if you just focus on these last 3 boxes here, patients who are always in one of these 3 boxes. If you have a young patient who's well, young patient who's otherwise well normally, and is acutely unwell like a COVID patient, then he's got a full escalation. So if he gets sick, you move him. If he gets sick, you move him to HDU. If he's still very sick, you move him to ITU. If he needs to be intubated, you intubate him. You do whatever you can, whatever it takes to make sure that patient gets through this rough period, because his chances of survival are very high. That's full escalation. Then there's a limited escalation. So these are patients who are quite sick, often have a DNR in place, but then you can say, okay, they have a DNR in place. That doesn't mean it's a death sentence. They can still receive non-invasive ventilation, or they can go to HDU, but not ITU. So there's a limited escalation plan for this man or woman. And then finally, you have a maintained current therapy or current care, which is ward level care. So this patient is on the ward. He's not suitable for HDU. He's not suitable for ITU. He's not suitable for a non-invasive ventilation. He's not suitable for cardiac monitoring. Ward level care is as far as he goes. So it doesn't matter what happens to this patient. He's just not suitable for any higher level of care, because that higher level of care will not benefit him any more than the ward level of care would, because his chances of survival are so low. And his complications are so broad that there's not much that HDU can do for this patient. Okay, so that's ward level ceiling of care. So there's various ceiling, and this is something you discuss or the consultant decides beforehand. And what you do is you make sure that when you come on duty and you find a sick patient and you see that they have a DNR in place, you say, what is his ceiling of care? Am I going to escalate him to HDU? Do I need to call HDU to make the HDU aware that this person might need to come? Or do I need to call ITU to make them aware that this patient might need to come? Or is ward level care all he's going to get? And I just need to speak to my registrar to see what kind of care on the ward that we can provide him best we can. Okay, so those are the important discussions. And before I move on, I just want to take a few seconds to highlight that the main point I was trying to make here is that, as with all these discussions, the involvement of the family or the power of attorney or guardian, whichever way you want to put it, is paramount. It is absolutely paramount. Often the patients will be incapacitated. They won't be able to communicate. They won't be able to express, they might have an advanced directive, but many patients don't have an advanced directive. And they won't be able to tell you what they want or what they need. And so really what you're doing is you're fulfilling the patient's wishes through their family. Their family will say, my mom wouldn't want that. My dad wouldn't want that. Or my dad would want that. My mom would want that. So you really need to have the family on board at each of these important discussions. The DNR discussion must have a family member informed. And the decision to palliate a patient must be, have a family member involved, unless the patient expresses otherwise. And the sealing of care, not as often, but often still, you inform the family that the clinicians have decided that his sealing of care is going to be ward level care, and therefore, because he's unsuitable to go to HDU, if he becomes worse or deteriorates, we're not going to move him to HDU or more intensive care units. Okay. So family involvement is paramount. Okay. Right. I'm going to talk a little bit about death of the patient, and I'm conscious of the time, and I want to make sure that I leave a little space at the end. So we will go through this in a relatively objective and quick fashion. So everything I've mentioned to you so far is relevant to this aspect. So you want to make sure that, in the death of a patient, if you're called regarding a death of a patient, you first ask, does the patient have a DNA CPR? And I'll tell you this one thing: as soon as a nurse calls and says, "Hi, unfortunately, Mr. So-and-so has passed away. Would you mind coming and confirming the death?" It almost automatically means that this patient was already anticipated to die, or you knew that he was going to pass away, or he was in his last moments, and he had a DNA CPR already in place. Simply because if someone otherwise dies, or their heart stops, somebody is pulling the emergency buzzer until a senior clinician is there and made a decision to not do anything. So if you get a call about a patient who's passed away, and the person on the other end sounds fairly calm, they will have a DNA CPR. Nonetheless, you must ask, did the patient have a DNA CPR in place? That's your job, because that's the difference between you running there and you walking there. Okay. So you'll get a call to say, a patient has passed away. You check whether or not they have a DNA CPR, or they have an advanced directive in place. The second thing you need to remember is family. Before you start doing other things, you ask the nurse, or you do it yourself. You make sure you inform the family. Okay. It doesn't matter what time of hour it is: 3 a.m., 4 a.m., 2:30 a.m., 2:59. It does. I don't care. If a member, or if patient passes away, and there are family members or power of attorneys directly involved in the patient's care, and I've been visiting him and asking about him, and the DNA CPR discussion was had with the son, and the palliation discussion was had with you, make sure you call that family member gets called, because these are the last moments that family member has with their relatives, with their relative, or their loved ones. Okay. So you make sure that you call, and the family's made aware. If they don't pick up, fine, but you do your job and you make sure that the family's been informed. And I mean, more often than not, pretty much every single time, the family member, once they find out, they come in the middle of the night to the hospital to see their loved ones for the last time, and give themselves closure. And to be honest, I wouldn't be surprised if there are cases where family members have sued the hospital for not informing the family members that their loved one has passed away. I'm sure there are plenty of cases of that. So you make sure that the family is informed, either by yourself or the nursing. And the nursing staff are excellent. They make sure they do this. So they, you don't have to. Finally, confirmation of death. There are two aspects to this. Firstly, I want to say again, you must respect the space of the family and their emotions. If the family members are there with the patient who's passed away, you must give them time. You go away, you do some other tasks that you have to do, and you come back, like an hour later, half an hour, whatever, because you want to give them time to have that closure and have that time to basically with their loved ones. And secondly, when you're actually confirming the death, this is probably more of a practical point, and I'm not going to dwell over it too much, but you should know the process of confirming someone's death. So you go in, you check the patient's identity, you see that they're not responsive, their eyes are closed, there's no sign of life, no respiratory effort, no response to verbal, painful stimuli, there's no central pulses, no peripheral pulses, there's no audible, heartbeat. There's no audible respiratory effort. and you say, I've confirmed the death on such and such date at such and such time, no concerns from staff members or patients or family, or you can say, I have given my condolences to the family or whatever. I need to remember that that is probably the last note that goes in that patient's record of medical care. And so you want to make sure it's nice, neat, legible. If you've had a chat with the family about anything, of the family raised a concern about anything, you make sure you document it in detail, because the consultant will look at that in the morning and say, okay, the family want to have a discussion with the consultant, or the family are worried about particular funeral or whatever it is. Okay, so you make sure that when you're confirming the death, that you detail it and document it properly. And then finally, documentation. Okay, so this is the fourth aspect of a patient's death, or death of a patient, is appropriate documentation. So ideally, you want to have the death certificate done as soon as possible. Often this cannot be done at night, because the consultant specifically needs to tell you what to put in these boxes here. These boxes talk about the main disease and condition from which the patient has died, then the secondary conditions that the patients had that contributed to their death. This has to be this has to be discussed with the consultant. It's his patient. He is responsible for that patient. He decides, or he determines, what is most appropriate to go into each box. Okay. If there's something on the death certificate that seems off, or the procurator fiscal picks out, which they do at random anyway, then they'll be contacting the consultant, not you. And they might contact you if there's an investigation, but it's the consultant who's ultimately responsible. So you fill out the patient's details and your details and the hospital details and so on and so forth. And then on this second page, or part C, that as it's called, you fill out the cause of death, primary, secondary, and so on and so forth. And this should be done very, by the next day should be done, because you have to remember that the patients can't arrange the funeral until they have this piece of paper. Until this death certificate, is organized and arranged and appropriately written and sent to the family, they can't begin the process of funeral arrangement. And you can imagine it's a stressful enough time for them already. And then they're having to call the ward and call the hospital and they call the doctors and ask for this piece of paper. You do not want to make it hard for them. You want to have this documentation done. And often the nurses, again, bless them, they will be on your case. They will be like, where's the death certificate? Where's the death certificate? Where's the death certificate? You'll be like, I don't know. I'm trying to contact the consultant. No. Where's the death? The family are waiting for the death certificate, because they know what the families go through better than you. And so, it's tough enough for them as it is. And then on top of that, they're having to chase you just to get this piece of paper. No, you get this done as soon as you can during the day after you've spoken to the consultant. Okay. So in the last few minutes, last 10 minutes or so, I'm just going to talk a little bit about my personal experiences, both as a medical student and as an FY1 in the hospital at the Queen Elizabeth, with the death and the passing of patients. I'll start with as a medical student. When I was a medical student, I think, I can't remember exactly what year. I think it must have been fourth year, because I was in a bit of a daze. Third year was awful and difficult. And in fourth year, we were just floating around from hospital placements, and it was very, very relaxed, and it was quite nice. We had a lot more time to think. And I was on the stroke ward, and I didn't really know anything about DNR and end-of-life care and patient death and everything. I always assumed that if a patient was to die in a hospital, we were all running as fast as we can to resuscitate him. And though I'd been taught about DNA CPR, I'd never really seen it in real life. So we were on a ward run, the stroke ward, at the Queen Elizabeth University Hospital, and we went in to see this patient, and he was quite poorly. He'd had a massive hemorrhagic stroke, and he had quite labored breathing, and he was unresponsive. Really, he was breathing, and he had a oxygen mask on, but he wasn't responsive. Maybe he was aware or conscious, but certainly not from what we can tell. And we reviewed the patient, and we stepped out of the room, and outside the room was two consultants, literally discussing what the evening plan for this patient was, because they were like, we're worried about him. They were arranging medication, escalation plans. We should give this dose, not that dose. They were literally discussing this patient. And while we were discussing this patient outside of his room, his family went in. And then literally, as we were moving from that patient to the next patient or the next room, like maybe 1 meter down from the room, I heard a scream from the room, and I freaked out, and I was like, what was that? And I was like, what's going on? Someone screamed. Why aren't people running to help them? But the patient had passed away at that moment when the family was in there. And obviously the relatives his wife had screamed and was crying. And I was massively distressed by this. I was like, why is nobody running or doing anything? I looked at the consultant, and he was very relaxed, very calm, and he just continued with his ward round. He gave his apologies to the nurses who were looking after him, because the family was still inside. And after a moment of, or I would say a moment, I said a couple of seconds of reflection, he moved on to the next patient. And the reason he was able to do this and I wasn't, because to be honest, I was very thrown off by that. I was incredibly thrown off, to the point where I did 2 more patients on the ward round. There was still an entire ward to go. And I asked the consultant, I was like, do you mind if I just leave? And he could tell that I wasn't feeling too well, and I wasn't doing too well as a result of this. And I left the hospital. I came home and I slept for 5 hours, and I woke up and I was fine after that. But it kind of hit me hard. And it's just because I wasn't anticipating it. I wasn't ready for this patient. I wasn't aware that he was DNA CPR'd, or what that meant, or what palliation meant. It was incredibly distressing for me. But for the consultant, he was able to just continue with his ward, because he knew what was happening. This patient was already at the end of his life. He already had a DNA CPR in place. He was palliated. The family were aware. The consultant were aware. Discussions had been had. Plans had been put in place. And so it was just a matter of when rather than if. And so when it did happen, even though it was so sudden, we literally went into the room and came out. He was anticipating it. He was prepared. So he handled it. Obviously, he has years and years of experience and probably seen this so many times, but still, he knew, and that made the difference. And so that was my experience as a medical student. And then as an FY1, I had a similar experience. The first time I had to confirm a death was on a night shift on the general surgical ward. And I was called by the nurse, again in a very calm fashion, saying, I apologize. I don't want to mention her name, of course, but she got called to say that the patient had passed away, and that she'd been peaceful, and there wasn't any acute, seizures or anything like that. And we already knew that the DNA CPR was in place, and we were anticipating her passing. So I went over to the ward, and I looked through the notes just briefly, made sure the DNA CPR form was there and was signed. And I was there. I looked into the room, and the lady's daughter was in there. And she saw me looking into the room, and she said, do you want us to step out? And I said, I said to them, just take your time. And they said, no, we can step out. So they stepped out for a second while I confirmed the death. I then stepped out of the room and gave my condolences to the family. And then I completed the documentation as appropriate. And then we arranged for the death certificate to be issued the next morning, because the consultant wasn't in at night, and we had to wait for his kind of approval before we did it. So that was the kind of process that I went through, and it's difficult the first time, and then it becomes easier because you're aware that these patients are already on end of life care. You know that the patient themselves are ready for this outcome because they've had these discussions and the families have had these discussions. So it becomes much easier to manage. And I can't emphasize the importance of having a DNA CPR in place when appropriate, because it can cause so much trauma and trouble and pain and grief to the patient, to the relatives, if you're on someone's chest trying to resuscitate them when it's absolutely futile and it's not going to work. So you want to make sure that even on the ward run during the day, if there is a patient that is incredibly unwell, they're end of life, and there's nothing more to be done for them, and the chances of resuscitation, or you feel the chances of resuscitation will be incredibly unsuccessful, just bring it up with your consultant on the ward run, or your senior registrar. Say, do you think this patient needs to be DNA CPR, or do you think he needs to be end of life care? And they will make the decision. That's fine. That's up to them. But if you notice it and you feel like, okay, I do not want to be the person at night resuscitating someone in a futile manner, causing extensive damage and injuries, and jeopardizing their dignity for absolutely no reason when it's not going to be successful. So you say, does this patient need to be palliated? Does he need to be DNA CPR? and then it's up to them. Like, you've done your part, you've raised the concern or the awareness, and then they make the decision as to whether or not they want to do that. So that's basically an important aspect to remember when you're on the wards. It will make your life easy. It will avoid unnecessary trouble. It will make life of your colleagues easy, and it will save you a lot of unnecessary injury. Remember, do no harm. And resuscitating someone when the chances of success are slim to none is doing harm. Okay. So remember that. That's a little bit about my experience. I've put this I've called put the snippet of this paper in. It talks about the implementation of weekend sealing of care intervention in surgical inpatients in additional health. It basically talks about the kind of things that should be in place before the weekend, because obviously there's no staff on the weekend, or there's very poor, minimal staff on the weekend. There's no active consultant on board. So basically, you want to make sure that the patient, if you need to know whether or not we have to resuscitate them. So is there a DNA CPR in place? Is he for cardiopulmonary resuscitation? Yes or no? You want to know that. Are they for rapid response? If the buzzer goes off, are you running? Yes or no? What is their ceiling of care? Is it ward level? Is it ITU? Is it HDU? What is their ceiling of care? And finally, what is the weekend plan? And that should be in the notes. Are we giving them more antibiotics? Are we withdrawing the antibiotics? Are we doing bloods? Are we not doing bloods? There should be a weekend plan in place. And I promise you, you do not want to be the person on the Saturday shift with a sick patient, with no idea of how far you're supposed to escalate him, with no idea of what his treatment plan is for the week, no idea what his ceiling of care is, or whether or not you want to know these things. And consultants will make an effort on Friday to make sure that these things are known and documented, are in place before the weekend, because it's going to be someone totally different who's usually not responsible for the ward on the weekend. Like I was today, I was covering a ward in a hospital that I don't normally work in. I was covering the entire ward by myself, and if anybody went off, I would have to go to the medical notes to see what the hell is going on. And if no one's bothered to put a weekend plan in place or documented anywhere what their kind of ceiling of care or DNA CPR status is, that is incredibly harmful, not just to being stressful for the doctor, but also to the patient. Imagine I started doing CPR when he was DNA CPR. Imagine the harm that I've caused. And imagine I didn't do CPR when he was for CPR, the harm that I've caused again. So having this information, available, I would say at all times, really is crucial. So that's a little bit about my personal experience and the kind of things you need to watch out for. I'll stop there. I think that's bang on time, an hour or so. And I just want to, before I say thank you, I want to just bring you back to this definition of palliative care. And if you remember at the start, I asked you to look at this definition and look at the words I've underlined. There's a purpose behind the words that I've underlined. Palliative care, the words, I'm going to focus just on the parts that I've underlined, or the parts that I've highlighted for you. Quality of life. You are not looking to improve the length of their life anymore, or the quantity of their life, or their ability to run anymore. You're just looking to improve their quality of life. And the quality of their life depends on what the patient holds valuable. Does the patient love running? Then you have to focus on their mobility. Does the patient just want to be pain-free? Then you focus on their pain. Does the patient want to go home? Then you may do whatever you can to make sure that his quality of life is high, therefore he's happy. So therefore we'll do what we can to provide the care that we can in his house. He might want to die in his home. That's perfectly human. So quality of life. Number 2, family. And I feel like I don't need to stress this anymore, because if you've not got that point, you've really not been paying attention. His family becomes almost like the patient that you're treating, because you remember that he will pass away, and it's important, obviously, he's the priority, the patient is the priority, but the grief and the after effects of that will affect the family. And you imagine how many patients or families weren't able to see their loved ones during COVID. We say, the patient passed away, but the trauma of that will be carried by the family because they weren't able to see their loved ones in their last moments, and really imagine the damage to the 5 or 6 people. That is traumatic. So the family is a big part. Relief from suffering. We try our best. Palliative care is about relief from suffering. We treat the pain, we treat the seizures, we treat the secretions, we treat whatever we can that is making them uncomfortable. We treat the infection as well. We give them radiotherapy to prevent symptoms. Everything we do is to control symptoms, and we're not limited as to what we can do to control or manage their symptoms. Early identification. So early identification to do with their DNA CPR, having the palliation discussions well beforehand, not like 10 minutes before they're about to crash. No, like weeks before they're going to crash or pass away. You have had these discussions and things are already in place. Okay. And then spiritual. I want to just focus on the spiritual because as doctors, we focus a lot on the physical and also the mental, because we know about mental health now, we're much better aware of it. But spiritual needs are crucial. People have religious beliefs, people have religious values, and especially near the end of their life, we need to make sure that those things are catered for. And this is the one thing that hospices are excellent at doing, that hospitals are not good at doing. They will make sure that the patient's religious beliefs and spiritual needs are catered for, whether that involves bringing in an imam, whether that involves bringing in a priest, whether it involves whatever, getting them to a temple, bringing the temple to them, anything. The spiritual needs are crucial, and it's often overlooked because people value different things, and for many people their spiritual health or their spiritual state might be more important to them at the end of their life than their physical state, or how much longer they can be kept alive. So that's their decision, and it's just perfectly valid. And to be honest, I don't think we as humans or even young people are too different. So anyway, I won't blather on too much. I think that's perfectly on time. Thank you very much. I'll open the floor to any questions. I'm sure Mohsin will be able to facilitate that. I'll also open the Q&A from the top.
I think what we're going to do is the first thing I'm going to ask everyone to do is if they can please fill in the feedback forms. So if you click in the Q&A, you should be able to see it. Now, this helps us a lot, naturally, because we know exactly what we're doing right and what we're doing wrong. Perfect. And of course, you can just scan the QR code, which will take you directly to it. I think with questions, I've had quite a few people message me questions as well. So if it's okay with Dr. Salim, I'll just read them out one by one. Just before I do start with the question, I did have quite a few comments regarding a copy of the presentation and the recording. Now, the presentations we don't normally hand out. The recordings, some of them are on the Study Medicine Europe YouTube page. But I think management is having mixed feelings about that. That might not be the case. I strongly advise everyone to try and tune into them while they're live. Okay, so let's get going with this. So the first question is, what kind of drugs are used in palliative care, and how does pain management work with palliative care patients?
Okay, so yeah, I've got a similar question here as well. So basically, palliative care. Basically, the WHO analgesic ladder is what you're looking at. So I didn't want to go into too much detail because I wanted to focus on the kind of legalities and key aspects of discussions. But in terms of, you start with the WHO man. So you basically, the first step of the WHO pain management or the analgesic ladder is basic pain medications, things like paracetamol, NSAIDs, Brufen and stuff like that. Then you go up to things like oxycodone, codeine and dihydrocodeine and things like that. Then you move up from that to things like morphine, oxycodone, and the opiate ladder. And then you go beyond that into other things. So other things can include like, having epidurals, having for, neuropathic pain, for having patient-controlled pain management, so they can control how much medication to give themselves depending on how much pain they feel. The basic principles of pain is two aspects. Number one, you manage the pain in a background, so you have a steady state of medication. So that's the regular medication. And then you have breakthrough medication, which is like your as and when required. So let's say someone might be on 10 milligrams of morphine 4 times a day. That's a high dose, but fine. It's not unknown. So 10 milligrams of morphine 4 times a day by syringe driver. And then when their pain gets specifically worse, they can have an extra 5 milligrams whenever they need it. And so the point is you have a background management of medication, so background level of medication, which is along the line. And then whenever they need some extra painkillers, they can take the PRN dose to give them a little boost in pain management. Now, if someone's using a lot of PRN, that means your background management isn't good enough. So you need to up the background and then give them boosts on the background of that. But it's titrated up the way gradually, and the palliative care team are very good at doing this. So that's how pain is managed. Mostly based on the WHO analgesic ladder, which you can look up. So that'll do that. Okay.
Thank you. Next question is, how can a medical student be useful in a setting of palliative care?
Really, I think just following the plan. Just following the plan. So there will be a plan set out, communication with the family, ensuring appropriate documentation is done correctly, managing the patient's pain. So contacting the palliative care team when required, because they're not on the ward, you're on the ward. So they know what to do, but they just don't know when to do it. So you need to contact them to ask them to give you advice. And communicating with the family, communicating with the consultant. You're literally the middleman between the patient and the consultant, because you're on the ward. The patients and the family will speak to you, and then you won't have all the answers. So you need to speak to the palliative care team, you need to speak to the consultant, and just being efficient with that kind of stuff is what I would say.
Okay. So the next question is regarding the COVID pandemic, and how were families limited to see their dying or dead relatives? As you say, they could get final closure. So how are they limited during the pandemic?
So actually, to be honest, in the hospitals, it was almost like we were figuring it out as we went along. And the rules changed almost on a weekly or a monthly basis. Initially, it was if someone is in the hospital with COVID, doesn't matter, like if they're end of life, not end of life, passed away, not passed away. We didn't let anybody into the hospitals, which it's cruel in a way, because the families don't get the closure. But initially at the time, we were so panicked by this and we didn't know how to manage it, and hospitals were short on equipment and everything, that was the way it was. And then over time, it's become, we allowed patients who were end of life care to have their relatives come up, only one relative at a time. Then as the situation became more and more under control, we allowed multiple relatives to come up for patients who are end of life care. And now we're at a stage where we allow patients to come up actively to see their family members. We just make sure that we test the patients regularly to make sure they don't have COVID. Different departments are different depending on their level of risk and their patient population, but it's become a lot more managed now. Initially, it was very, very restricted, and often patients, I'm not one for peddling horror stories, but it wasn't uncommon to hear initially in the outbreak that the patient would pass away in the hospital. They would be taken to the mortuary. The funeral arrangements would be made remotely, and then only 5 members of the patient's family could attend the funeral and not even see the body, because the patient passed away from COVID and therefore couldn't be exposed and just had to be buried. So it was incredibly difficult initially, but now it's gotten to a stage where we can manage it a lot more effectively, of course, with the vaccinations and everything that's in place now. Hope that gives you some insight.
Thank you. Have you ever broke bad news to a patient, and what was your experience?
No, I personally haven't. As an FY1, you will not be the one bearing the bad news. I've been asked by a consultant to sit in on breaking bad news, and that's often because you need 2 clinicians, one as your witness or you're almost like a chaperone, really. So no, you as an FY1 should not be asked to break bad news. It should be a senior clinician. Unless, no, I can't think of a situation where that would be the case. If you're an FY2, maybe, if you know the patient well and you understand the situation, and a senior clinician has a discussion with you to tell you what to discuss with them, then maybe. But really, no, you won't be asked to break bad news by yourself.
Okay. So this next one is quite interesting. What happens if the patient goes into a coma?
A coma?
Yeah.
If the patient goes into a coma, I think, really, like, you just manage it accordingly. It depends on who the patient is. Like, if it's a young, healthy, fit man who's had a brain injury or spinal injury, then he'd be taken to ITU, intubated, and managed and ventilated accordingly.
If it's an elderly man who wasn't expected to die, he might be taken to ITU, managed with intubation, and then taken off the ventilator, at some point when we've decided it's not going to recover. If it's an elderly man who was anticipated to pass away, then if he goes into a coma, we manage him best as we can without intervention or ventilation. And then we allow them to pass smoothly if we don't think there's any prospect of recovery. So it depends very much on the patient.
Okay. Another one, just for clarification in regard to verifying death. Does the auscultation need to be for 3 minutes continuously or in intervals?
I would say continuously. I think you listen to the heart continuously for 3 minutes. 3 minutes is the, by some standards, some places will say 1 minute, some places will say 3 minutes. You certainly don't want to do it less than 1 minute, to be quite fair. But you do it continuously. And if you don't hear anything, then you document that you haven't heard anything for the period of time that you listened.
Okay. So what happens to a patient who has no next of kin and has not made funeral arrangements?
So it's taken over. There's a specific service that takes over these kind of cases. And I'm not sure privy to the exact details. If the patient has capacity, the patient themselves make the decisions of their care up until they become incapacitated. When they become incapacitated, the clinician, the senior consultant or the senior clinician makes the decisions for the patients in their best interest because they have no next of kin. And then when they pass away, I'm really not sure what happens beyond that point. I know that there is a procedure and service in place to take care of these aspects. I am unsure of exactly what that procedure or service is. But it is taken care of as far as I'm aware, and I would anticipate that it is.
Patients who want to die at home, how are they dealt with?
We do what we can to facilitate their care at home. So if we can get a syringe driver and pain management to their house, we will get it there. If they need oxygen at home, we will take an oxygen tag to their home. If they need medication at home, we'll take. If they need carers to toilet them and move them around in the house, we will do that. We will facilitate that. We do what we can within the service provisions to provide and make sure that they get they're comfortable near the end of their lives. And if they want to pass away in the house, then it's perfectly valid. So that's what we do. We basically, I don't want to say we move the hospital to their house, but in many senses, I've seen it happen. We genuinely move the hospital to their house to make sure that they are in a place where they're comfortable. Often it's more manageable and quicker to do it in a hospice. So the hospice is like a kind of end of life, you can say, care facility. And so they will have the facilities there already. And so it's very easy for us to move them there where they'll get the treatment as in palliative treatment they require near the end of their lives.
Amazing. I think that's all the questions from me. I'm just looking through the Q&A box to see if there's anything new. I think there's some questions in regard to how hard your work is as a FY2 and what is expected of FY2 doctor. If you want to have a crack.
I think that's a very generalized question. It's a lot easier than FY1 is all I'll say. A lot easier than FY1. You have a lot more experience. You have a lot more experience. It's not absolutely new. You're not climbing a mountain anymore. You're kind of walking up a hill now because you know what you're doing. You have a lot more responsibilities, but at the same time, you're doing a lot more specific tasks. You're in patients rather than taking bloods. And you're not stressed out about tasks as much, though there are still days where I'm working nonstop. So it's a lot nicer. I think if you can get through FY1, of course for Bulgarian students, I'm aware that or European students, I'm aware that sometimes they come in and go straight into FY2. I'm not particularly a fan of that, to be honest. I feel like FY1 was probably a crucial experience and kind of makes me the clinician I am today. Gives me the confidence that I have today. So FY2 is a lot easier than FY1. So that's a generalized question. I'll just read through some of them myself, if that's okay, Mohsen.
Sure.
How to approach patients about DNA CPR. Like I said, use the spikes model, just, space, making sure you have time, space, inviting a family member, and then summarizing at the end. So I would just stick to that model if you don't have another one. What drugs are you? We've talked about that. If a family hesitate, then what do you do with CPR? Families do hesitate with CPR. I think we try our best to convince the patients to understand and the families to understand why we're doing this and how much we feel it's not going to be successful. At the end of the day, it is the clinician's decision. But I've seen many clinicians and consultants bow to the will of the family and the patient because you do not want to be making that decision solo. Even though you can, as a consultant, you can say, look, this patient is not going to survive CPR. I am not going to do CPR. It doesn't matter what it is. But this is very rarely done. Like consultants will acknowledge the feelings of the family and the patient, and they will try again and again and again to convince them of this, rather than just making a unilateral decision. Let me just quickly go through some of these a little bit more, and then we'll call it there. So, what does PRN stand for? Okay, so PRN is drugs that you take or medication that you take as and when required. So, salbutamol, for example, for asthma, you don't just take it like 4 times a day or 2 times a day on a regular basis. You just take it when you need it and as often as you need it, kind of thing. So that's what I meant with medication, is that there will be pain medication that they take regularly, which is their background pain management, and then they will take PRN medication as and when they require it for kind of acute pain that comes and goes throughout the day or so on. So that's PRN. I think I've kind of a DNA CPR has been put in place for a patient. They do not want to receive CPR. However, as they begin to struggle just before their heart stops, they say, please help me. Alfred Matthew, what an interesting question. I'm sorry to point you out. What an amazingly interesting question.
Because you get that a lot. I think when I was in the hospital doing my placements, you would get patients who weren't on DNA CPR who would say, help me, or please help me. But
I think in that situation, you do what you can to make the patient comfortable. Whether or not you do CPR is an incredibly tough question. I guess if they still had capacity, then, and you could assume that they changed their mind about the DNA CPR. And therefore you might say, okay, well, he's asking for help. He's asking to be resuscitated. Again, if their chances of resuscitation are so slim to none, is there a point of resuscitating them? But I guess by the definition of them having asked you to do something and you not doing it can be considered quite cruel. And therefore I feel like it would take a very tough clinician, a very tough minded or very stern clinician to say at that point, no. So I think the majority of clinicians will then at that point spring into action and do what they can. Having said that, by definition, if someone is dying or is in cardiac arrest, they won't be able to say, help me, they'll be passed out. So it will most naturally be before they need CPR that they're crying out for help. Okay. So at that point, you can give them oxygen, you can give them medication, you can give them pain management, blah, 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 blah. They can give all these things. Once their heart stops beating, they're not going to be conscious. So this scenario, I feel like I haven't seen this before because it doesn't really happen. Someone goes into arrest, they're not talking. So at that point, there is no cry for help. Okay. It would be very incredibly difficult to not help someone if they've cried for help, and be very difficult to justify as well. So I don't think this happens. I want to just for the interest of the students who are still here, and I don't know how many, but really just for your interest, there was a very, very interesting case written. It was an American journal I was reading. It was a patient who hadn't previously been known to the hospital, and he arrested. He was brought in, but when they went to shock him, they took his shirt off. It said, "Do not resuscitate," tattooed on his chest. Or it said something along the lines of, "Do not resuscitate me if I die." And this was a case study that was written up in a journal. And I remember reading it, and I think in the end, you can imagine the dilemma, because there's no official paperwork. You don't know this patient. You don't know if he was serious when he got that tattoo or he was drunk. You don't know anything. You just see "do not resuscitate" written on his chest in tattoo. So I think in the end, they decided not to resuscitate that patient because they said, well, no one would get that tattoo on their chest without understanding the consequences of what that means. And it became a very, interesting case simply because it doesn't happen that often. You can get that sometimes, but before you resuscitate elderly patients, especially, you start the resuscitation if you need to, but then while you're doing the resuscitation, someone else should be checking in the background in the notes on the computer, does this person have a DNA CPR? And as soon as someone says he has a DNA CPR, you stop resuscitation because you're like, okay, we didn't know, we did what we had to do, and now we know, and now we stop. So, you just work with the information that you're given. The default is everyone is to be resuscitated unless specified otherwise. Okay. So if you don't know, you resuscitate.
I actually remember reading into this case study quite a while ago, and I always ask this question to people just to see what they would say. And actually, like when I think somebody wrote a big long article about it afterwards, telling what actually happened, and turns out the doctors actually did resuscitate him because the guy didn't have an ID on him, so they couldn't confirm who he was. And then they started calling lawyers and people from the ethical board, and it turned into a whole different thing. And turns out they found out he actually did have a DNA CPR, but he went back into arrest like 4 hours later. This time, of course, not resuscitating him, and passed away. So it never got turned into a lawsuit, thankfully. But yeah, no, that's honestly
like I said, as a clinician, you deal with what you have in front of you. So while you're trying to figure out whether or not to resuscitate him, you resuscitate because you don't know, so you resuscitate. And then in the midst of that, you try and figure out, and like you said, like eventually, when they did figure it out, they didn't resuscitate. But actually, the point I was trying to make is that if you didn't know in that situation, what do you do? And so you can initially resuscitate, but then it has to be a team decision or a consultant together in like a quick, urgent MDT discussion with the lawyer, everybody involved, to say, okay, do we not resuscitate? It can be a tricky decision, but unfortunately, it's something for very senior clinicians to make who have plenty of experience with these scenarios. So I think, you won't be alone in that situation. But I just thought it was an interesting case, and I'm glad you've read it as well. So it is definitely worth a read if you have the time. Okay, I think that was all I had to say. And thanks everyone for listening in, and thanks for your questions as well. So yeah, I'll leave you there if that's appropriate.
Perfect. Thank you so much, Dr. Salim. Thank you so much for your talk. That was really great. And thank you everyone for being here. I think we'll have our next webinar next month. Please don't forget to fill in the feedback form. I'll leave this call open for a little while for the people who still want to access it. It should be in the Q&A box. And yeah, if you do have any questions, message us on our social medias or email us. Not a problem either way.
Okay, thank you very much. Thank you. Okay, bye-bye.
Thank you. Bye.